All right, here's lesson F in 150. It's the last lesson in the 150 assessment and treatment course. And we kind of wrap up this thing with a discussion about the neurological system and how it has control of circulation, ventilation, oxygenation. Do some definitions, assessment, and emergent interventions just like always. So here's the background. The neurosystem is in command and control of the cardiovascular and the respiratory systems. And so while we spend a lot of time to this point talking about CVO, circulation, ventilation, oxygenation, those are functions of the cardiovascular and respiratory system. The neurosystem is in command and control over those two systems. Anytime we talk about neurosystem and command and control issues, we need to talk about blood glucose also, and we know that that's part of the endocrine system. But for purposes of this, we're kind of conceptualizing blood glucose as part of this whole neurological system function, because your brain needs a continuous and adequate supply of both oxygen and glucose. It has no ability to store either of those, and so they have to be delivered just in time for consumption in order to make energy so that cells all over the body, but particularly in the brain, can do their thing. And so if we're going to talk about functioning of the neurosystem, we need to make sure that blood glucose is included in that. The neurosystem in this context contains the brain, the spinal cord, and the nerves. There's a whole lot of anatomy that you could dig into here, probably beyond the scope of what we need to know as field paramedics. Our program is not trying to teach you everything about the human body. We insist on you learning everything you need to know about the human body, anatomy, physiology, pathophysiology, in order to assess and manage your patients. But we don't need you to fill up your brain with a whole bunch of detailed semi-trivia sorts of things. If Mrs. Smith doesn't need you to know it, we're not going to insist that you learn it. And so we spend a lot of time on what really matters and not very much time on some trivia. If you want to go further and know more, there's nothing wrong with that, and it may help you a little bit. But we're not going to spend a great deal of time on the anatomy piece here. We're being more conceptual in terms of brain, spinal cord, and nervous system. So field assessment of the neurological system, the field neuro exam, can be done in most cases in a minute or two. Probably should be done on lots of your patients. If for no other reason, do it to obtain some experience and a baseline for what is not abnormal. So if your guy fell and twisted his ankle, maybe you want to do a field neuro exam on him at an appropriate time. We should examine his ankle and deal with that. But there's nothing wrong with doing field neuro exams on people who don't appear to have any problem with their neurological system. It helps you get more reps and helps you be more comfortable with what a baseline norm would be. So what's in a field neuro exam? Well, there's several things. There's a pupil check, there's a stroke screen, there's a cranial nerve check, and then we want to know if they can move their arms and legs. And in some cases, it's appropriate for us to assist our patient and observe them as they walk to the cart. A lot of times I think we have patients walk to the cart because we don't want to lift them. But in some cases it is diagnostic. We also think a Glasgow Coma scale is part of an overall neuro assessment. We pull that out separately. It's not part of the field neuro exam to us. And blood glucose also. So if you're going to assess a patient's neuro system, you check their GCS, you check their glucose, and you do this field neuro exam. So let's get into what all this looks like. Pupils. The pupils should be round, they should be equal, and they should react to light. Pearl. There are a number of people who have a variant that is not abnormal, called anisocoria. Now, prior to redoing these lessons, I had a misconception. I thought anisocoria was simply the physiologically normal variant where people have a little bit of different sizes to their pupils. But what's actually technically correct is that anisocoria means unequal pupils. That may be physiologically normal variant for them, or it may be pathologic, in which case they have, it's an indicator that there's increased swelling inside their cranium, elevated intracranial pressure, and they have unequal pupils. A blown pupil has been slang for many years and still is, and the picture shows you a very dilated pupil on one side and a constricted pupil on the other, a blown pupil. There's nothing wrong with the pupil. It's not an eye problem. It's a nerve problem. It's the optic nerve being pressed on in the cranium by elevated intracranial pressure. Everyone has intracranial pressure. It's elevated intracranial pressure that we're worried about. So some of our recent students, when we ask a question about what is going on here, they say intracranial pressure. Well, what they mean is elevated intracranial pressure. So elevated ICP can cause pressure on the nerve that controls the pupil, and the pupil responds abnormally and is then abnormal size, unequal size. So anechoria technically is unequal sized pupils. That can be a big deal or a normal thing. How do you check pupils? Well, it's not like they do on TV. So we need to know that when you shine a light in the right eye constricts. When you shine a light in the right eye, the left pupil constricts as well, and vice versa. And so that's part of the pupil check in our neuro assessment. Next thing that's part of the field neuro exam is the Cincinnati Pre-Hospital Stroke Scale. There is an LA Pre-Hospital Stroke Scale. There's a Miami Stroke Scale. There's not a Columbia Stroke Scale that I know of, but it seems like there are numerous scales out there, and they're all good. The CPSS is what has been adopted in our state. It is reasonably, it's a reasonably good assessment tool for some strokes. It's pretty good at catching anterior strokes. It's not good at all at catching posterior strokes. So you should realize that while the CPS is a very simple stroke scale that can be done by family members, by bystanders, it can probably be done by the patient looking in the mirror. Slurred speech, facial droop, one-sided weakness. When you have them talk, they're a little slurry. That can be from other things as well. They have one side of their face is droopy compared to the other, and they have one side of their body is weak compared to the other. We used to test grips, now we do pronator drift. In lab for this, we'll make sure everybody's doing the CPSS correctly. And to even get into that lab, you should be able to name the three parts of it, and this is EMT stuff. But the additional thing we need you to know is that, wow, this is a very simple to do scale, and it is pretty good at catching some strokes. It's terrible at catching other strokes. Matter of fact, it may miss 1 in 3. So the fact that your patient flunked the stroke scale, had slurred speech, facial droop, one-sided weakness, is a pretty good indicator they're having a stroke, or at least we need to treat them like they're having a stroke and hope it turns out to be a TIA. But the fact that they cleared the stroke scale, they passed it, they had no slurred speech, no facial droop, no one-sided weakness, does not rule out a stroke. Matter of fact, up to maybe 1 in 3 strokes are not going to trip the trigger of the Cincinnati scale, and yet they turn out to be real strokes, and in some case, extremely critical or life-threatening. Here's something on cranial nerves, another example of how we approach things. We do not care that you are able to name all 12 cranial nerves. I don't think we even care you know that there's 12, but probably you should know that there's 12. They emerge from the brain and the spinal cord kind of above the brainstem, so these are high up. Emerge from the brain above the cord in the brainstem area, they're high up, and they control the senses, hearing, seeing, smelling, tasting, and they control head and neck movement. So if you want to learn all the names and know them in order, that's nice. But we need you to be able to test them. And some we're not going to test in the field. It's kind of hard to test taste in the field. Smell is even iffy. But we can have a gross check of the cranial nerves. We can say the cranial nerves are grossly intact or there are deficits. And we can do that by doing a field test to see if they can see, hear, smell, taste, and if they can move their head and neck. Can they smile? Can they stick their tongue out? Can they grimace? Can they shrug their shoulders? Can they push against resistance, moving their head? Can they do these general things? It's part of the field neuro exam. It's quick and easy. And again, naming and numbering is not our concern. Nothing wrong with you if you know that, but just make sure you save space in your brain for the stuff that matters, because naming them doesn't matter. So again, how do you test it? We'll do this in lab, but you have them stick out their tongue and smile, move their eyes in all directions, shrug their shoulders, push against your hand. There are other things we can add to that in terms of peripheral nerve testing, in terms of GAIT, or in if they're able to spread their fingers and hold their fingers spread against resistance and all their arms and legs work well. And there's lots of things we can do with that, but we need you to have a basic understanding, and we'll deal with some of that in the lab setting. Coordination and gait, again, I mentioned earlier that it's okay to walk your patient to the cart in some cases. I don't think it's okay for your shortness of breath or your acute coronary syndrome patient to walk, maybe stand and pivot, but to walk up and down the kitchen floor or walk out down the sidewalk as a diagnostic for them makes no sense. It's actually adding to their myocardial oxygen demand. But in the case of trying to test coordination of gait, it may be appropriate for you to do. Again, with appropriate spotters, someone there to help if things go wrong. Can they voluntarily control movement of their arms and legs, touch a finger to the nose, balance? It's not quite a field sobriety test, but there's elements of that, and able to walk as normal for them. A change in that could indicate a change in their neurostatus. Glasgow Coma Scale, important for you to know. We think that paramedics should have this memorized. We don't think that you'll have it memorized in this course, but we think by the end of the program, you should have it memorized. And there's a couple of key learning points here. And so you've seen this as EMTs, and there are many variations of this out there in terms of how things are worded. We picked one that we thought was worded most appropriately. And so, eye-opening. This is AVPU. Does he spontaneously look at you? Is he alert when you walk up to him? Or in order to get him to open his eyes, do you have to speak? They don't have to speak. They just have to open their eyes. Or in order to get him to open his eyes, did you have to put pain to him? And we like nail bed pressure. We don't like sternal rubs. We don't like nipple twists. We don't like orbital pressure. We don't like a lot of other painful things. We like nail bed pressure. We don't want to leave a mark, and we don't want to assault our patient. We're trying to do a diagnostic test. On the verbal response, be sure you understand what is confused versus what is inappropriate words. The analogy I like to use is that if you ask the guy, what is today, and he gets the right day of the week, he's oriented. If he gets the wrong day of the week, he's confused. If he doesn't even pick a day of the week for his answer, that's inappropriate words. It's not that he's cursing, it's that he picked the wrong word. And you say, what's today? Tuesday? Well, it's Monday, so he gets confused. But if you said, what's today? And he said, bananas, well, that's not even one of the possible choices. So, incomprehensible sounds is pretty clear. No response, pretty obvious. Look at this. Remember that a perfect score is a 15. A dead guy gets a 3. If it's less than 8, you probably ought to consider intubate. And, that's kind of where this goes. It also is used as part of trauma center and other TCD alert screening. So it's important that we be able to calculate a GCS. Initially, if you need to have a reference card, that's fine. We're not going to make you a badge buddy for the GCS. We think that you should get that pretty quickly. But if you need one in the meantime as scaffolding or a crutch, so to speak, that's fine. But you need to move on past that pretty soon. On the best motor response, be clear on what you are seeing there in terms of localizing or withdrawing. and then also be able to differentiate decorticate and decerebrate. And this chart shows you pretty well. So if you pinch the patient, put nail bed pressure to the patient, and he pulls away from that with that hand, he has localized the pain to the hand where you place the pain. If he pulls away and kind of startles all over, then he is withdrawing from pain. So he doesn't get withdraw from pain just from pulling back with that one arm that you put the pain to. It has to be both arms and legs, and he is trying to get away from pain, which indicates a lower functioning brain and neurosystem than if he was able to say, yes, you pinched my left, put nail bed pressure to my left hand, I'm going to pull back with my left hand. And then decorticate and decerebrate. The key things here, and you may need to write this down, the key things here, their neck arches and their feet extend with both. It's what they do with their arms that matters. Flexion, abnormal flexion with extension of the neck and extension of the toes is decorticate posturing, and that is bad. Abnormal extension of the arms, along with extension of the toes and arching of the neck, is decerebrate posturing, and that is worse than bad. So decorticate, decerebrate, you should know them. At the paramedic level, we should be really, really good at this. There should be no misunderstandings here. And some of you probably came from EMT already knowing this sort of, but would at least be able to apply this scale if you were given a scenario, and that is part of what we're certain you should know by the end of this course. Then by the end of our program, by the time you're done with field clinicals, you come into your summative exam, you should be able to know the Glasgow without a reference. Blood glucose, again, we said, we know it's the endocrine system, but glucose is necessary for the brain to function. So how do you get that finger stick? Don't forget that finger stick. Can you use the patient's glucometer? Sure. May give you some trending stuff. Know that if it's high, that usually means more than 500, but that varies by the meter. We think that most of the glucometers that are out there in the field these days, 500 is the number. I'm not sure why. It won't give you the actual number above 500, but it just does. And so when you see high on that reading, it's not just the meter being friendly to you. It's telling you that that glucose is greater than 500, and you ought to know that. So interventions on blood glucose, interventions on neuro patients, if they have an abnormal low glucose, then that can mimic a stroke. And so that stroke scale that they flunked may not indicate a stroke if their glucose is 30. So we got to fix the glucose, then recheck your neuro. Don't forget airway and breathing. And when you are in the presence of a patient that you believe is having a stroke or similar neurocatastrophe, a stroke alert is imperative here, and it is part of good patient care. Time is brain cells, and so these patients will need that. So in Lab F, we're going to practice that field neuro exam, practice some GCS stuff, make sure you're good on finger stick and getting the glucose out of an IV stick and all those kinds of things, and make sure that you are able to kind of wrap up this whole assessment of your patient, not just with the CVO that we've worked on, but also with including that neurosystem exam. So we'll see you in Lab F.